Let me tell you something that happened in a neurology clinic in Tokyo in 1987 that most American doctors have never read about, and probably wouldn't believe if they did. A group of patients with severe peripheral neuropathy, people who had been told their nerve damage was permanent, that management was the only option, that this was simply the new reality of their lives, were given a single compound, not a drug, not a procedure, a vitamin, in a specific form, at a specific dose, delivered in a specific way. Within 14 days, measurable nerve regeneration had begun. Not pain reduction, not symptom masking, actual structural repair of damaged nerve fibers, confirmed by nerve conduction velocity tests, confirmed by patient-reported sensation returning in limbs that had been numb for years. I've spent a long time wondering why that research never made it into mainstream American medicine. I'm going to stop wondering out loud and just show you what they found, because if you have tingling, burning, numbness, or that awful electric shock feeling in your hands or feet, what I'm about to tell you is probably the most important thing you'll hear this year. Before anything else, I need to ask you one specific question. Does your neuropathy get worse at night? Not just present. Worse. That burning, that restless crawling feeling under your skin, that electric current running through your feet, does it specifically intensify when you lie down, when the room is quiet, when there's nothing left to distract you from it? If yes, type it in the comments, because that single symptom tells me something very precise about what's happening inside your nervous system right now, and it's directly connected to everything I'm going to explain. I want to tell you about Margaret. Margaret is 61, retired nurse, which, if you think about it, makes her story more painful, not less, because she spent 30 years taking care of other people's bodies and couldn't figure out what was destroying her own. For 4 years, she had neuropathy in both feet. Burning during the day, electric shocks at night. She'd tried 3 different medications. She'd done physical therapy. She'd changed her diet. She'd spent probably $4,000 on supplements that promised nerve support and delivered nothing. What nobody had ever done, not one of her doctors, was test her B12 in a way that actually meant something. Her blood work always came back within normal range. She was told her levels were fine, and technically, on paper, they were. What her doctors didn't know, or didn't think to check, is that the standard lab reference range for B12 is set so low that you can have clinical neurological damage actively progressing while your results say normal. Margaret switched one supplement, one form, one delivery method. 8 weeks later, she told her doctor she felt sensation in her left big toe for the first time in 3 years. Her doctor called it remarkable. Margaret called it infuriating because she'd been sitting 4 years away from a $10 supplement and nobody had pointed her there. So let's talk about what's actually happening inside your nervous system. Because once you understand the mechanism, everything else clicks into place and you'll never look at a B12 bottle the same way again. Every single nerve fiber in your body, from your spinal cord to the tips of your toes, is wrapped in a layer of insulation. It's called the myelin sheath. Think of it exactly like the rubber coating on an electrical wire. That coating exists for one reason: to make sure the electrical signal traveling down the wire gets to its destination cleanly, without leaking, without distorting, without misfiring. Now imagine what happens when that insulation starts to crack. The signal doesn't travel cleanly anymore. It leaks. It fires at the wrong moments. It arrives distorted. Some signals don't arrive at all, which is where numbness comes from. Others arrive amplified and chaotic, which is where the burning and the electric shock pain come from. Your nerves aren't generating pain because something is hurting them in that moment. They're generating pain because they've lost the ability to communicate normally. They're damaged wires sparking. That process, the breakdown of myelin, is called demyelination, and there are many things that can trigger it: diabetes, autoimmune conditions, chemotherapy, alcohol, physical compression. But the single most common, most overlooked, most reversible cause of demyelination in adults over 40, B12 deficiency. Not because B12 is magic, because B12 is structurally essential to myelin production. Without adequate B12, your body literally cannot manufacture or maintain the insulation around your nerve fibers. It doesn't matter how healthy you eat. It doesn't matter how many other vitamins you take. If your B12 is functionally low, your myelin degrades. Period. And here is the part that should make you genuinely angry. B12 deficiency is one of the most correctable conditions in medicine. It costs almost nothing to fix. The research on its role in nerve repair is decades old, and yet millions of people are walking around with progressive neurological deterioration that a $10 supplement could interrupt because they were told their levels were normal when they weren't, or because they were given the wrong form, or because nobody ever explained that the way you take B12 matters as much as whether you take it at all. Let's start with the lab range problem, because this one genuinely infuriates clinicians who actually study this. Most standard labs in the United States flag B12 deficiency below 200 picograms per milliliter. That's the cutoff. Below 200, you're deficient. Above 200, you're fine. Except you're not. Neurological research, peer-reviewed, published, replicated, has consistently documented active nerve damage in patients whose B12 levels sit between 200 and 400, levels that every standard lab report would mark as normal. In Japan, where B12 research has been most extensively conducted, the functional threshold for neurological health is considered to be closer to 500 to 600 picograms per milliliter. American labs haven't updated their reference ranges to reflect 40 years of subsequent research. So if you've had your B12 tested and been told it's fine, get the actual number, not just the flag, the number. If it's under 500, there is a credible scientific argument that your nervous system is operating without the raw materials it needs to maintain itself. And if you have neuropathy symptoms on top of that, the picture becomes very clear. But here's the thing. Even knowing your number isn't enough, because the next problem is absorption, and this is where most B12 supplementation quietly fails. When you swallow a standard B12 tablet, your body doesn't just absorb it directly. It has to be escorted through your gut wall by a specific protein called intrinsic factor, produced in your stomach lining. No intrinsic factor, no absorption. Simple as that. Here's what the supplement industry doesn't put on the label. Intrinsic factor production declines with age. If you're over 40, you're producing less than you were at 25. If you're over 60, the decline can be substantial. Add to that anyone taking acid-reducing medications, proton pump inhibitors, H2 blockers, because those drugs change the stomach environment that intrinsic factor depends on. Add anyone with a history of gut inflammation, celiac, Crohn's, gastritis. Add anyone who has had gastric surgery. That's not a rare population. That's an enormous percentage of the people who actually develop neuropathy. And all of them could be swallowing 1,000 micrograms of B12 every single morning and absorbing 15 of it. The rest exits exactly the way it entered. This is why people take B12 for a year and feel nothing. It's not that the vitamin doesn't work, it's that it never got into their bloodstream in the first place. So here is what the Tokyo research used, here is what Margaret used, here is what the clinical literature actually supports for nerve regeneration. Methylcobalamin, not cyanocobalamin, which is what you'll find in most multivitamins, most budget B12 supplements, most of what's sitting on the shelf at your average grocery store. Cyanocobalamin is the synthetic form. It's cheap to manufacture. Your body has to convert it through multiple steps before it becomes neurologically usable. Every step in that conversion chain is a potential failure point, especially as you age, especially with gut issues, especially in people whose cellular machinery is already compromised by the neuropathy itself. Methylcobalamin is different. It is the bioactive form. It's the form your neurons actually use. There is no conversion required. It enters your system and goes directly to work. The clinical studies on methylcobalamin in peripheral neuropathy, and there are a significant number of them, going back to the 1980s in Japan, replicated in Germany, in South Korea, in clinical trials in the US, consistently show the same things. Improved nerve conduction velocity, meaning signals traveling faster through damaged nerves. reduced pain scores, return of sensation in previously numb areas, and in the most significant studies, using high doses, measurable regeneration of nerve fibers themselves. The dose that produced the clearest results in the literature sits between 1,500 and 3,000 micrograms per day for active neurological recovery. This sounds high compared to the 500 microgram tablets most people buy. It's not dangerous. B12 is water-soluble, meaning your body removes what it doesn't use, and there is no documented toxicity ceiling for oral or sublingual intake. But the dose matters. A maintenance dose won't produce the same results as a therapeutic dose. And most people taking B12 for neuropathy are on maintenance doses because nobody told them otherwise. Now, the delivery method. This is the piece that actually determines whether everything else works. Even methylcobalamin, if you swallow it, still has to pass through the same absorption pathway. Still depends on intrinsic factor. Still faces the same gut barrier that makes conventional B12 supplementation fail for so many people. The solution is sublingual delivery. Under the tongue. The tissue under your tongue is densely supplied with capillaries, tiny blood vessels sitting just below a very thin mucous membrane. When you place a sublingual tablet under your tongue and let it dissolve, fully dissolve, over 60 to 90 seconds, the methylcobalamin absorbs directly through that membrane into your bloodstream. It doesn't go near your stomach. It doesn't need intrinsic factor. It bypasses every single absorption failure point that has been silently defeating conventional supplementation for years. This is not experimental. Sublingual B12 has been studied as an alternative to B12 injections, the gold standard for patients who cannot absorb oral B12, and shown in multiple studies to achieve comparable blood levels. It works. It works specifically because it routes around the gut entirely. So when you put this together, methylcobalamin, therapeutic dose, sublingual delivery, you are doing something categorically different from taking a cyanocobalamin tablet at breakfast and hoping for the best. You are delivering the neurologically active form of B12 directly into circulation, at a dose that clinical research has connected to actual nerve fiber regeneration, bypassing every physiological barrier that has kept conventional supplementation from working. That is why people who've taken B12 for years and seen nothing sometimes start this protocol and notice changes within 2 weeks. It's not a different vitamin, it's the same vitamin, finally getting to where it needs to go, in the form the nervous system can actually use. There are a few things that work alongside methylcobalamin that the research supports clearly, not as replacements, but as genuine amplifiers. The first is vitamin D3. There is substantial evidence that vitamin D plays a direct role in neurological repair through pathways that are separate from and complementary to B12. Deficiency in both is extremely common in neuropathy patients, and addressing only one produces partial results. If you haven't had your D3 levels tested, do it. If your level is under 50 nanograms per milliliter, supplementing D3 alongside methylcobalamin is supported by the research. The second is magnesium glycinate. Magnesium is involved in the electrical stability of nerve cell membranes, the surface through which nerve signals actually fire. When magnesium is low, nerve membranes become hyperexcitable. This is one of the mechanisms behind the tingling, the hypersensitivity, the burning that seems disproportionate to any physical cause. Magnesium glycinate, specifically glycinate, because it's the form best absorbed and least likely to cause digestive discomfort, has been studied in combination with B12 for neuropathy and consistently improves outcomes compared to B12 alone. The third is sleep. And I'm mentioning it because most neuropathy patients don't realize it's a treatment variable. Your nervous system conducts the majority of its cellular repair during deep, slow-wave sleep. If your neuropathy pain is waking you up at night, which for most people it is, you are being robbed of your primary healing window every single night. One of the earliest benefits many patients report from the methylcobalamin protocol is that pain intensity drops enough within the first 1 to 2 weeks to allow longer, deeper sleep. And when sleep improves, the rate of nerve repair accelerates. It compounds, which is why the 14-day window is real for some people. Not because the vitamin works instantly, but because reducing pain enough to restore sleep creates a feedback loop where healing genuinely speeds up. Here is what I want you to do tonight. Not tomorrow, tonight. Go find your current supplements, your multivitamin, your B12 if you take one, anything in your cabinet. Read the label. Look for the word cyanocobalamin. If you find it, that's your answer. That's why it hasn't worked. Tomorrow, find sublingual methylcobalamin. Most health food stores carry it. It's available online from multiple reputable brands. You want a dose of at least 1,000 micrograms per tablet, ideally 1,500 to 2,000. Place it under your tongue first thing in the morning, before coffee, before food. Let it dissolve completely. Don't rush it. 60 seconds minimum. Don't eat or drink for 10 minutes after. Do that every morning. And keep a simple pain log on your phone. Just a number, 1 to 10, every morning before you get out of bed. Write down what you feel in your feet, your hands, wherever your symptoms are worst. Most people following this correctly notice something shifting between day 7 and day 12. Not dramatic, not overnight, but a shift, a quieting of the signal, a reduction in the intensity, sometimes the beginning of sensation returning somewhere it had gone silent. That shift is your nervous system responding. That's myelin beginning to rebuild. That's not a metaphor. That is cellular repair. The same process documented in the Tokyo research, the same process Margaret experienced, the same process that the research has been pointing to for 4 decades while most people were handed pain medications and told to manage their expectations. Your nervous system is not broken beyond repair. It is starving for something specific, in a form it can actually use. Now you know what that is. Now you know why the version most people are taking doesn't work. Now you know how to fix it. The only question left is whether you're going to do something with that information tonight, or file it away and keep waking up at 2 a.m. on the bathroom tile.